Robert Taub is a professor of medicine at Columbia, and he's really devoted his career to developing treatments for both pleural and peritoneal mesothelioma. He's perhaps developed one of the biggest practices of peritoneal mesothelioma that I'm aware of, and has really been a fine clinician for a huge number of patients, treating them with intracavitary chemotherapy and multimodality approaches. We also have one important legacy to thank Dr. Taub for, and that's Mary Hestorfer, who worked as his nurse practitioner back in the day until she moved on to her current role. At any rate, Dr. Taub's going to be talking about treatments for peritoneal mesothelioma.
Thank you very much. Let's see where we are here. Yeah.
It's you.
No, that's not me. I wouldn't know how to speak about that.
Here we go.
Yeah, that's me. Okay.
There you
So just to recap what Lee said, I do run a program at Columbia in peritoneal mesothelioma, and it's mainly devoted to taking care of patients with peritoneal mesothelioma. We actively pursue new treatments in the lab, in the clinic, and also by bioinformatics. So I hope we can serve as a resource to you and to patients who need care and information. Mesothelioma is a cancer which can arise, of course, in pleural membranes, which cover the lungs and surround the heart, or the peritoneal membranes, which cover the stomach and the intestines. And this talk is going to focus on the peritoneal mesothelioma, which makes up about 15% of reported cases, which is about 450 cases a year in the United States. Peritoneal mesothelioma often starts with a huge buildup of ascites, fluid in the abdomen with thickened and stiffened peritoneal membranes, leading to irreversible intestinal blockage. And the peritoneum eventually gets filled up with these masses and does interfere with bowel function. Many cases of peritoneal mesothelioma, like the pleural disease, are associated with heavy, repeated asbestos exposure, such as is found in the insulation, construction, shipyard, and automotive brake workers. From 1940 through 1979, 27.5 million American workers were occupationally exposed to asbestos. In China's Yuyao province, if you take a look at the picture on the left, women are still employed in 2012 to spin asbestos fibers, and more than 50% of 280 cases of mesothelioma in women over the past few years were abdominal rather than pleural. And we think that this is because much of this asbestos is swallowed by these women rather than inhaled, but we really don't know. Other causes for mesothelioma, of course, have been identified. The zeolites, which are silicate rocks that resemble asbestos and probably cause mesothelioma as well, are abundant in the southwest United States and in Turkey. And mesothelioma is also seen about 5 to 10 years after radiation therapy for other cancers, such as prostate or breast or uterine cancer. You can get mesothelioma about 10 years after that as well, without asbestos exposure. Now, when looked at under the microscope, the mesothelioma cells are of three main types. There is epithelial, consisting of small round cells, and sometimes which form tubules. There is the sarcomatous variety, which consists of elongated spindle-like cells. And then there's the mixed type with a biphasic which has elements of both. Now, a few patients who have been diagnosed with mesothelioma actually have a non-malignant variant compatible with a normal lifespan and who really don't require treatment. And these are the benign cystic mesothelioma, which you see at the left, and the well-differentiated papillary mesothelioma as well. This is all the more reason why you should not diagnose mesothelioma from a very small sample, and that you should actually trust only a pathologist who has had a lot of experience in making this kind of a diagnosis. Clinically, peritoneal mesothelioma comes in several different flavors that differ in their clinical course from tolerable and slow growing to invasive and rapidly progressive. And we're starting to think that these are actually different diseases. The tubulopapillary patients in this graph, which are 34 of the 160 unselected patients that were operated on at our center, had a longer median survival, and 8 of them, or 28%, survived more than 9 years, compared to 10%, or only 12 of 128 non-papillary patients, and 1 of 18 sarcomatoid patients. So the epithelial and sarcomatoid groups also differ substantially when they're studied by gene microarray analysis, and they cluster separately into distinct groups. The therapies that work for epithelial mesothelioma are much less effective and don't work well at all in the sarcomatoid. Mesothelioma cells don't divide properly. When normal cells divide, they split evenly and meticulously so that each daughter cell ends up with 23 pairs of neat chromosomes, seen on the left. In mesothelioma cells, mitosis is corrupted, so cell division is very abnormal. The chromosomes break up and reattach in unusual ways. Some chromosomes are completely or partially lost, and others may be copied multiple times. The result is a confusing mess, as seen on the right, with any number of chromosomes from 20 to 100 or more per cell. And this means that the genes on these chromosomes may be missing, and their function is diminished or lost. Alternatively, the gene is duplicated and may be hyperactive. Notice here, for example, that chromosome 14 is missing in this cell, but in other cells of that same tumor, neighboring cells, chromosome 14 may be split, only parts of it may be missing, or it might be intact. So these are actually different clones of cells which can coexist. Sometimes these changes actually follow a pattern if you look properly. And this shows that in 10 of our peritoneal mesothelioma patients who were heavily exposed to asbestos, they developed characteristic multiple gene losses in chromosome 14, which you can see here, which was not present in those patients who got their mesothelioma from radiation. And so this suggests that asbestos-related and radiation-related mesotheliomas developed by different mechanisms and may well be also different diseases, although the cells look alike under the light microscope. Now, whether this change will serve as a signature for asbestos-induced malignancy is something we're looking at now. Peritoneal mesothelioma was considered 100% fatal until about 1984, when Antman and her colleagues showed that the combination of cytoreductive surgery and intraperitoneal chemotherapy could eradicate the disease in some patients. Currently, cytoreductive surgery is the accepted treatment. Cytoreductive surgery is the accepted treatment, but it's not yet standardized, nor can it be done for all patients. The treatment protocol we use at Columbia involves an initial exploratory laparotomy, which means opening up the abdomen and exploring it at surgery. omentectomy, which is removal of the fat pad covering the intestines, which people don't seem to need anymore, debulking of tumor whenever possible, followed by heated intraperitoneal chemotherapy, and the placement of right and left intraperitoneal catheters, tubes attached to metaports subcutaneously. We then give outpatient intraperitoneal chemotherapy repeatedly for 12 weeks. So these patients, after surgery, come back to the office and get chemotherapy instilled into the abdomen. And a second look operation is done after 3 months. Any remaining disease is excised, and the intraperitoneal catheters and metaports are taken out. At the time of the second surgery, they get a second heated perfusion. After that, the patients are followed at 3-month intervals until 18 months, then 6-month intervals until 3 years, and then yearly. This shows the exploratory laparotomy and removal of the omentum, which the surgeon is holding on to. The omentum is infiltrated by mesothelioma. In this particular patient, disease on the other mesothelial surfaces was fairly thin, which will allow chemotherapy to penetrate it. We do not attempt at surgery to remove this kind of disease because you actually can't do it. And so we don't aim for a radical peritonectomy, but intend that chemotherapy will eradicate it. So during the first operation, as I mentioned, we place 2 intraperitoneal catheters, 1 on each side, which allows us to switch between them when giving the outpatient chemotherapy. The metaport chamber rests on a rib, as you can see, and the catheter extends from the port into the peritoneal cavity. All of this surgery is well tolerated. It is an exploratory laparotomy, but it's not huge, monstrous surgery where things are taken out. The average intraoperative stay, postoperative stay in the hospital is less than 6 days. After 8 courses of outpatient chemotherapy, 4 each of doxorubicin and cisplatin, the abdomen is re-explored and remaining disease assessed visually and by multiple biopsies so that we really know visually what we accomplished by the surgery. The abdomen is once again perfused using a closed system roller pump mechanism primed with cisplatin for 90 minutes as shown here, and the abdomen is then closed. This operation is also ordinarily well tolerated, and the average post-op stay is less than 6 days, making a total surgical hospital stay of about 12 days for both operations. Now, combined cytoreduction and intraperitoneal chemotherapy for abdominal mesothelioma is accepted treatment, but it is not standardized. So we at Columbia do 2 operations, 2 high-pack perfusions, sandwiched around 8 outpatient intraperitoneal treatments. The reason we do this is that we believe unashamedly that chemotherapy is more effective than surgery at removing thin disease. Surgeons at other institutions believe in their heart that chemotherapy does nothing and that all cancer needs to be cut out. They therefore do a single, more radical operation, often with removal of bowel or other organs, no second look, and limited outpatient intraperitoneal treatment. In all fairness, treatment at each center has been shown retrospectively to be effective in prolonging survival. But we have not compared institution to institution in terms of patient selection, operative morbidity or mortality or quality of life. And this needs desperately to be done. Now, just as in pleural mesothelioma, let me move this on. Conventional chemotherapy for abdominal mesothelioma is a reasonable option for patients who can't tolerate or do not desire surgery, especially if they have symptoms that might be improved by shrinking their tumor. The only FDA-approved treatment right now is the combination of pemetrexed and cisplatin, as you all know, which temporarily shrinks tumors about 20% of the time and has been shown to prolong median survival. Ralatrexate plus platinum is similarly active in European studies. Gemcitabine plus a platinum drug may also be active, although pemetrexed and gemcitabine combinations have never been compared head-to-head, perhaps because they are both sold by Eli Lilly and Company. The only other positive phase 3 trials were carried out in the 1990s and probably need to be done again, showing activity of doxorubicin and mitomycin in combination with cisplatin. Now, it probably doesn't matter for patients receiving chemotherapy. It probably doesn't matter which drug you use first. If it doesn't work, you should try a different one, because a subset of tumor cells might exist that will respond to the second drug. So that this lesson here is that at this moment in time, no drug or drug combination should be expected to cure your disease. What it can do is buy quality time, hopefully enough time to allow us to find new drugs, new discoveries that will either prolong or finally and ultimately cure the disease. So it's a question of containment, and it's a question of prolongation, and it's a question of maintaining quality of life. Now, we live in an exhilarating scientific time when each year's advances in genomics brings us closer to understanding the entire process of tumor development, as Dr. Krug alluded to. Hanrahan and Weinberg have summarized the properties, now numbering 10, that characterize a cancer cell, and drugs have been developed that block each one of these properties, so we have an armamentarium to use. Thus far, we have tested many inhibitors of cell surface growth factor receptors, compounds which help stabilize the genome, and none of these drugs, I have a nice long list over there of drugs that have been tested in mesothelioma and have not done very much. None of these drugs have been effective in more than a tantalizingly small number of patients, and those that delay tumor growth do so for only a few months. But there's no reason to think that it's not going to happen, because it's already happening for some lung cancers, and it's already happening for some subsets of melanoma. And right now, exciting compounds include some of the modified antibodies to mesothelin, which selectively attach to mesothelioma tumor cells and which release powerful cellular poisons which kill all cells touched by the antibody, vaccines against mesothelioma-related antigens and also against the WT1, and regional gene therapy with modified viruses will also show promises in early trials. But again, they're early, and we hope that they're going to do something. One day, one of these is going to do everything that we want it to. So how should patients choose treatment? Previously untreated patients who are symptomatic from advancing disease should first choose conventional chemotherapy drug that has a recognized record of objective responses and tumor shrinkage. Because if you've got symptoms, you want your tumor to shrink. So you've got to take a drug that's going to have a record of shrinking tumors. On the other hand, previously untreated, asymptomatic patients who are feeling well but know from studies or from imaging that they have progressive disease, they might first choose experimental treatment, because this way they're going to have the option of getting new drugs. And this way they can get conventional treatment at any time later. As I said, it doesn't matter which one you use first. Conventional treatments are not all identical, and patients need to ask their doctor to justify the choice. A combination of knowledge of the literature, extensive personal experience for the doctor is best. You have to trust your doctor. Most local oncologists have seen very few cases of mesothelioma, in which case they should check with their colleagues at a major center. Ask your doctor about expected benefits, possible risks, and quality of life during treatment. Ask to speak with other comparable patients whom that doctor has treated. If a doctor is too busy to answer your questions, he should be turned out of office. A second opinion obtained before treatment starts is always a good idea, no matter how your oncologist is esteemed or recognized or beloved. If you call Marv and speak to Mary, she will recommend a second oncologist. Asymptomatic patients in whom the disease is progressing on CT scan or PET scan should consider a clinical trial. It might be the only way that they might get a new active drug while retaining the option of conventional therapy. If you go this route, remember, first, more than 80% of experimentally tested phase 1 and phase 2 drugs are found to be totally ineffective. Hesitate before enrolling. Don't pin your hopes on any one drug. Be prepared to try several. Second, choose late-stage phase 3 studies or investigator-initiated phase 2 studies that have a clear rationale, one that can be explained to you, and in which care will be provided by the doctor who is doing the study, both during and after the trial. He should be your doctor during and after the study as well. Ask whether the investigator will cover the costs of care that might be incurred if there are unexpected adverse effects or side effects. This is something that institutions love to avoid. You have to make sure that they have something in place for you. The investigator, again, meaning the doctor taking care of you and not a surrogate, should spell out all the risks and possible benefits of the study and answer all questions. There should be a lot of questions. Ask to speak with other patients who have gone through the trial, and the trial should have a quality of life component so that you can find out from other patients how they fared during the study. Just to conclude, in 10 years, there are going to be fewer asbestos-related peritoneal mesothelioma cases in the United States. There are going to be more such cases in China. Drug treatment will be determined by genomics and will be much more successful. And surgical treatment and intraperitoneal treatment will at least be better standardized, but at best will be unnecessary. Thank you.